Well, thank you very much for the invitation to this symposium. I would like to talk a little bit different issues. That is myomyositis-associated keratoconjunctivitis. It is not a pure dry eye, but somewhat that could also cause the evaporative dry eye. Well, this is not the meibomian keratoconjunctivitis, which I'm talking about. Meibomitis-related keratoconjunctivitis. Sometimes, if this is a mild type cases, you can see this is a meibomitis. You can see the frectennular keratitis, and it used to be when we see the frectennular keratitis, that is probably due to the tuberculosis or other diseases. But recently, when we see that this kind of the frectennular keratitis, at least in Japan, that is not related to tuberculosis. I will talk to you about the later in the pathogenesis. And moderate type, this is no more frectennular keratitis, but you can see the superficial vessel ingrowth with the nodular formation with some of the infiltrate associated with the meibomitis. And this is the severest form. Again, the meibomitis as well as some kind of nodular formation with superficial vascularization. We published the one or two papers in AJO years ago, but I'd like to talk to you more about this meibomitis-related keratoconjunctivitis. This picture shows you just a regular frectennular keratitis, but please note the upper the lids, especially the meibomian gland. And you can easily understand these inflammation, especially this area. This is not the obstructive MGD because when we see the patient is like this. The girls, especially the adolescent or the young ladies, they tend to show this kind of meibomitis-related keratoconjunctivitis. But they may have some kind of gender-associated diseases. When we culture the meibium from these patients, before that we clean up and squeeze and try to get the meibium. This is actually the normal subject. I just want to show you how to collect the meibium and then the cultures, the anaerobic as well as aerobic, the bacteria. And about 2/3 of the patient of the meibomitis-related keratoconjunctivitis did show the P. acne. P. acne is a kind of a commensal bacteria, so you cannot say P. acne is the pathogenic for this disease. But at least from this meibium, about 2/3 of the subject showed P. acne, followed by the staph epidermidis and staph aureus, so on and so on. So therefore, about 10 years ago, we performed this kind of experiment using rats. This is we sensitized the rats by the killed P. acne or killed staph aureus. And then we inject the killed P. acne or killed staph into the corneal stroma in rats. And then the result is obvious. P. acne, pre-sensitized cornea, did show the infiltration into the corneal stroma. This is a kind of a delayed type hypersensitivity. P. acne is a very strong inducer for the delayed type hypersensitivity. And nowadays, some of the scientists claim that P. acne is the primary cause for the sarcoidosis as well. But anyway, so the P. acne could induce, if this is sensitized, could induce this kind of DTH as well. And then back to the severest case of the so-called meibomitis-related keratoconjunctivitis. She is a 28-year-old female. Bilateral visual acuity is a hand motion. When I saw her at that time, we thought this may be due to the P. acne. So this is not the first case. So at that time we are thinking that the elimination or the decrease of the bacteria such as P. acne in the meibomian gland would be essential for curing ocular surface inflammation. So this concept is basically quite similar to those for the gastritis associated with Helicobacter pylori. And then we use systemic treatment of the cephalosporins followed by the clarithromycin systemically. We do not use any steroids or any immunosuppressives systemically as well as topically, because this is a kind of a clinical experiment. So, and this is 1 month and 3 months later, but all these are cured and cornea become clear and clear. So this is not a corneal infection. This is a kind of infectious kind of allergy type things, which we thought. And then we published one paper in the AJO, and we collected about just 23 patients under 35 years of age. And among them, 80% are the female. And there are many patients shows the Charretier history at that time. And then the meibium shows the P. acne positive. And more interestingly, these has some kind of HLA associated the problem, especially the HLA A26 at addressing the Japanese populations. So since then, we are collecting these kind of patients. Now we have over 100 cases or so, at least in my department. And again, these are the young female, multiple history of Charretier, including the young girls or so, and then when we got the positive culture, that is a P. acne, and then HLA. So this is another case of the meibomitis-related keratoconjunctivitis pre-treatment, and this is 2 months post-treatment. The treatment is an antimicrobial agent alone, and you can see the big difference, and also the meibomitis released spontaneously. So again, I'd like to show you one more time the same picture as I showed you the initially. Meibomitis-related keratoconjunctivitis is a variety of the ocular surface manifestation, including the mild type, moderate type, and a severe type. And then when I took a meibography from the patient with the meibomitis-related keratoconjunctivitis, you can see the partial dropout of the meibomian gland as compared to the normal subject. The normal subject, you can see beautifully the meibomian gland extend over to the tarsal conjunctiva. So this disease, category of disease, is different from meibomian keratoconjunctivitis proposed by Jim McCurry in 1977. This is, you can see, the rather elderly patient associated with the obstructive MGD that could cause the thinning of the tear film lipid layer, and also that could cause the evaporative dry eye, SPK or so. But meibomitis-related keratoconjunctivitis could seen in predominantly in young females. And then ocular rosacea. Japanese, we do not have not much of the ocular rosacea, but this clinical entity is quite similar between the meibomitis-related keratoconjunctivitis and the ocular rosacea. And there are several papers showing that ocular rosacea, especially in a childhood, the systemic antimicrobial agent is quite effective to treat these the children with the ocular rosacea. So my keywords is if the host genetic background is somewhat abnormal, at that time commensal bacteria, even the commensal bacteria, and if this is a mucosal innate immunity is somewhat abnormal, commensal bacteria could do bad things as well. So I'd like to acknowledge my colleagues and these colleagues, co-investigators working seriously for this project. Thank you very much for your attention.